Actually, right now it's whatever.
Well, informally, yes, sorry. First, let us meet our guest presenter, with Dr. Jackal Sullivan, who I first met. I think you might have been an intern. It's been some years. For some years, I said, "Oh, Jackal is super smart, little MD and PhD, I believe, who's done some amazing work, but also just very conscious, very thoughtful physician as well, but also doing amazing scientific work." Before we dive into the actual talk part of this. Jack, just tell us about yourself. Who are you? Where'd you grow up? How'd you end up here? Why are you doing what you do?
Yeah, I think I got a little bit incorporated into it, but I grew up in Australia, went to medical school in Australia, went to Oxford, did a PhD there in biostatistics genetics, then came to Stanford 7 years ago. First came as a postdoc for about a year with Euan Ashley, working on statistics, genomics, polygenetic scores. And then for the last essentially five and a half years, did my clinical training, so I did internal medicine with Jonathan, fast track on the physician science pathway and into cardiology. I'm now just a fourth year cardiology. I think I sometimes joke with patients. I think I'm a PGY 11. Yeah, that's 11 years ago. Anyway, so then as of July last year, I transitioned to 80% research, 20% clinical. So I see patients with inherited cardiomyopathies, inherited genetic heart disease, a couple of days a week, and then the rest of the time is research interest in broadly machine learning and medicine with the additional focus I'm not going to talk about today on genetics. I'll be staying on at Stanford as an instructor, attending cardiologist, and want to be starting my own clinic in the inherited heart disease clinic for next life.
I didn't realize you were a Paris postdoc before your residency.
Yeah.
You're already embedded in time with the research ecosystem. And
Yeah.
Why don't you even go back to residency then?
I do love seeing patients. I do really love seeing patients. I think the combination is really great. You see patients, they inspire your research, your research inspires them. I think it's broadly just how you can be the most impactful with your time. I think we can do a lot of direct impact, seeing and looking after patients, and then we can be impactful and be about broad changes to help this system.
Well, that's awesome. So I definitely caught wind of your preprint in this space. It was some months ago. I was like, oh, that's super cool. Totally thematic things I'm very excited about, but also really touch a lot of computational informatics issues at that interface. I know you've been active working on it. You can have some timely results to show on it. So if you could please take it away. I unfortunately have to run to another meeting, so I won't be able to stay present physically, but very excited to listen in on Dr. Jackal Sullivan. Please take it away.
Yeah, thanks, Jonathan. Thanks everyone for coming. I'm going to talk about the democratization of subspecialty medical expertise. I'm going to talk about large language models in the clinic. Don't have any disclosures. Importantly, I don't have any disclosures from any of the large language model makers, unfortunately, what I say. We can probably skip over this, just a little bit of my journey from Australia, Oxford, and then Stanford. And then today, what I want to talk about is what we've done, what we're doing, and then what we're going to do next for large language models in the clinic. So I want to provide some background about what inspired this preprint I'm going to talk about. And that's the global shortage of medical expertise. So I'm a cardiologist, so I think about cardiology things probably too much. For every 1 million people globally, we have 80 cardiologists. That number's true globally, that number's true in the US. It's also true in Brazil. Some of you may have seen about a month ago, there was a big non-cardiac, non-medical event. Lady Gaga at a concert. There's 2 million people there. So I guess I'm not formally a mathematician, but I think there's probably about 160 cardiologists there. And I think for me, that really draws into attention the scale of the incongruence between patient and provider. So the overarching question that I'm hoping to answer today is, can large language models bridge that gap? Not in Brazil, not the conference, but in healthcare in general. So what have we done to try and address that? This is the preprint Jonathan and Nigam were referring to. What I'm going to talk about is the background and the results for that preprint. So specifically within cardiology, I specialize in inherited genetic diseases of the heart. And this incongruence, this disconnect between the number of patients and number of providers is, in my opinion, more acute in these conditions. The specific condition that's the most common is a disease called hypertrophic cardiomyopathy, and it is life-threatening, and it's the most common cause of sudden cardiac death in young folks. So why is this a problem? Well, there's subspecialty clinics for hypertrophic cardiomyopathy. We have one at Stanford, one at UCSF, but half of the US states have no cardiologists that are subspecially trained in hypertrophic cardiomyopathy. This is problematic because estimates leave about 60% of these patients with hypertrophic cardiomyopathy undiagnosed in the US. This is pretty bad. As the most common cause of sudden cardiac death in young adults, we have one of the most clear-cut life-saving interventions we can offer, which is an ICD, implantable cardiac device. So it's really a tragedy if someone is misdiagnosed, undiagnosed, they have a sudden cardiac death. That is very, very preventable. You may have come across this over your life. On the right, for the Europeans in the room, is a guy called Christian Eriksen. He had a sudden cardiac arrest, I should say, on the field. He was resuscitated. We don't know exactly what he had. And then probably the most famous American with hypertrophic cardiomyopathy and then did die on the field is Reggie Lewis. I don't know, apparently he was a Celtics basketball player. So back to our overarching hypothesis in our study this time. Is there a way that we can find these patients better and get them to the appropriate cardiologist better? So this is the overall study design preprint. I'll talk about broadly now and then in detail. But what we did is for about 200 patients that were suspected to have inherited cardiovascular disease. So they were referred to us in clinic. We got their text-only physician reports for these six cardiac tests. The genetic test when it was ordered, ECG, the electrical heart rhythm in one point in time, the ambulatory Holter monitor, often known as a Zio patch, cardiopulmonary stress test, which we really stress the heart, resting and stress transthoracic echocardiogram, cardiac MRI. So we had all those 6 tests just in text form. I'll explain that a little bit more. And then we gave these text-only reports to 2 groups. One to Google's large language model, it's called AMY, and the one to a non-Stanford, California-based community cardiologist, so general cardiologist, no subspecialty training in any inherited genetic conditions. We asked them, basically, what is your overall impression, what's your management of these patients? I'll go into the specifics later. They produced basically a physician report with the large language model cardiologist. And then we asked 4 of our Stanford Center for Inherited Cardiovascular Disease, our subspecialty genetic cardiologist, to review these 2 assessments blindly. A lot of information. We'll go through that.
Go back for a second. Just to respond. Was that 3 arms or 2 arms? Or
there is I will talk about the 3rd arm later, but there was a 3rd arm.
Okay.
Briefly, after this, we decided this a priori, but after those 2 arms had been done, we then gave the cardiologist back their answer. And then we said, well, also here's Amy's answer. Can you produce an augmented answer for us? Do you want to change things? So we'll go through that, but that's coming later. So just to hone in a little bit on this, because there's a lot of information, this is an example of one of the text reports, for instance, that both groups got. You'll see small left ventricular cavity, normal systolic function, severe asymmetrical hypertrophy, mitral valve, caudal systolic, anterior motion of the mitral valve. This is a sort of snippet of what the text that the cardiologist in the large language model saw. The side point, I worked quite hard and successfully to get all of this data open sourced. So all of this text data for those tests is de-identified, currently online for anyone to use for model training, model evaluation. It's on, and I can talk through the process to do that. So then we gave that text to these 2 groups. We specifically asked them these bunch of questions. We asked both Amy and the cardiologist separately, what do you think overall is going on? What's your overall assessment? For anyone who's been to a doctor or is a doctor, that's sort of the main thing that we all read, a qualitative assessment about what's going on. We then asked them a specific consult question. do you think the patient has genetic heart disease? The background of the 200 patients, probably about 75% did have genetic heart disease. And there were some controls on that. And then we asked, this is trying to get to this issue of democratization. Do you think this patient needs to be referred to a subspecialty clinic? The cardiologist or the large language model at that point could have requested more information. That was a multiple choice answer. Then we said, what's the most likely diagnosis? How would you manage this patient? How would you treat them? I will highlight a couple of questions. First is we asked both groups. You are not able to see this patient, you're not able to interact. It's an important part of clinical care. If you were able to, what would you ask them? And specifically, what would you ask them that would help you refine your diagnosis? And we asked the same thing for how you would refine your treatment, your management. This is an example on sort of skiers right. We have the text that both groups saw, just a snippet of it. And then on skiers left, you'll see two answers. Just a snippet of them. The first thing that might come into your mind, at least came into my mind, comes into a lot of people's mind, is the difference in length between both of these. You probably all know that large language models are slightly more verbose. So the light blue answer, cardiologist answer, is shorter. The large language models is longer. This is the same patient. You'll see they disagree about this patient. What's quite interesting about this example is they both highlight a hyperdynamic, hypercontractile left ventricular function, and then this left ventricular alpha obstruction. The large language model goes on to reason a little bit more about why it thinks there's a certain diagnosis. And then the cardiologist says, no, I don't want to refer, and the large language model says, yes. So that is an example of our subspecialists have to say who got this right or wrong. To give you an indication, this is a full answer from the large language model.
Quick question.
Yeah.
You're repeating in text reports of 6 different tests. Correct. By the time someone's gotten that level of workup, they're already in a specialty track.
Very good point. So this was one of the reviewer comments of this paper. There's two ways we thought about this. One, not all patients had completed the workup. There were some patients that, particularly the two probably advanced tests are the cardiac MRI and the genetic testing. So there was a subset where the results mirrored the rest of them. And then we tried to address this a little bit in the extension of this study that I'm going to talk about later in, where we basically tried to mimic more what a general cardiologist would see in the community. But yeah, great question. I think that came up a lot, and it's probably definitely a limitation of this data. Okay, so we've talked about tests that people had access to. We talked about the assessments that was performed by the large language model and the cardiologist. Then those two assessments were given to our Stanford genetic cardiologists. We basically gave them and created a web interface for our cardiologists to log into. It looked a bit like this. They had access to the same clinical text. And then they were asked, which of these two answers do you prefer? Obviously, they were blinded. We didn't tell them which is which. We asked them to compare overall, so the overall impression, taking everything into account, whatever is important to them. And we also asked them across each of these domains. So for each of these questions, which do you prefer? These are the results from the preprint. The red is the large language model. The darker blue is the cardiologist. The light blue is a tie. I'll highlight the top, which is this overall impression, probably the more important result. Overall, what did you prefer as the subspecialty genetic cardiologist expert in this field? And there was a significant, but I would say marginal preference for the large language model. My take on this, how we describe this in the paper, is these are comparable results. I think the large language model did as good a job. It was preferred to a similar degree. We then asked,
so you said you blinded them, but you said that, like, as we know, LLMs make like super, it's like, I can tell when ChatGPT is writing something. So how did you address that? Like,
absolutely. I think for these results, it's not addressable. The second, what Jonathan asked me about, the third arm addresses this to some degree, which I'll talk through the results. The third arm was basically ended up comparing cardiologists by themselves and then cardiologists rewriting their assessment, having seen the large language model. So in that way, that was definitely more blinded. I can't think of a way to directly compare large language model and cardiologists. I think it's always going to be really obvious. But that was a way we tried to suggest we could get around it. But I don't think it really truly addresses the lack of blinding in direct comparison. Yeah. Okay, we're at, yes. So then we also asked the same subspecialty cardiologists across both of these assessments. Was there evidence of these 5 things basically? So as these 2 gentlemen in the back has already pointed out, large language model had more content, not unexpected. Across the other domains, you know, how much was admitted, evidence of correct reasoning, and a bias against certain demographic groups, so probably even. Then you'll notice that the large language model, our subspecialists thought that the large language model made more clinically significant errors. Probably quite a compelling result. So then, to address already some of the questions that have come up, we have a third arm. So a priori we said, all right, you're a cardiologist, this is the answer you originally gave, this is what the large language model thought for the same patient, and you rewrite your assessment. Then we compared with our subspecialist, blinded again, original answer, augmented answer. Same interface, same assessment. Then we asked and generated the same results, same plot. So you'll see in the red, that's cardiologist plus large language model, darker blue cardiologist alone, light blue tied. You'll see that this time, across the entire response, the large language model with the cardiologist augmented by the large language model was quite strongly preferred. If you look across the domains, it's probably management, where this is coming across most compelling. So what I mean by management is, once the diagnosis is clear, what do you want to do? We'll talk a little bit about this at the end, but I think that does reflect what large language models are very good at. Once it knows the diagnosis, it gets a diagnosis right, it's not going to miss things. I think it's less good when there's clinical nuance. Yeah.
So these results go against what Amy team themselves have reported in their own paper, that Amy alone outperforms Amy plus clinician, and including Jonathan's results are also similar, that the unaided model is better than the augmented clinician. This is like exact opposite to those 2 studies. So what are your
My thoughts on that? The 2 papers I think you're referring to, I think, were primary care physicians being augmented. I think that's one difference. This is cardiologists being augmented. I think cardiologists probably have some familiarity with these conditions. I think primary care is so broad and really hard to be able to remember it. But I think the biggest difference here as well is when we get referred patients often the time when no one really knows what's going on. Probably 20 to 30% of the time, we have a patient that doesn't meet a clear phenotype. They have some abnormality in this MRI, they have some abnormality. So when we've looked through this data in detail, that is really hard for a large language model to deal with. It doesn't know what to do with it. It always wants to anchor onto some answer. And I think why we're finding the augmenting in these results, I think it's a little bit to do with that as well. Because I think the clinician will say, I think the extent of our scientific knowledge, we do this in clinic not infrequently, we can't give you an answer, even last week. We can't put you into a box. The large language model does want to seem to put people into a box. So then it will be wrong. If that answers your question. Oh, yeah.
And how was the new rewritten reports like as a follow-up to his question, could you tell which one was
That's a good question. I think if you really, if the same cardiologist got the same case, which we tried to avoid, it's possible that they could have remembered, oh, that was the first answer and this is the second answer. But in general, we tried to encourage the cardiologist to sort of completely rewrite it. There's probably some small percentage of cases where the cardiologist just added one line or something. And in that case, it probably is identifiable. Now, we know that the large language model sometimes suggests too much. So there's a possibility that actually that could have been wrong, and the specialist could have preferred the other thing, but I think there's, the blinding was much better. Was it absolutely perfect? Probably not, but pretty good.
Thank you.
Just as a follow-up to that, is there like an objective endpoint one could use rather than, just like the action, right, that's informed by the case report itself?
Great question. I do think this is a great question broadly for the field. I think when we think about what defines clinical cardiology care and probably clinical medicine care in general, it's like large 5-year randomized controlled trials where the endpoint is death. So I think, it might be up to the FDA, it might be up to clinicians to see whether we want that standard to be achieved before these are in the clinic. But I think that would probably be ideal. We randomize people and say, we're going to follow you for 5 years. The large language model said this, the clinician said this, let's follow you up. But I don't know if anyone's going to do that study, I think. We could possibly do things like hospitalizations, that sort of stuff, but all of those endpoints are like million dollar trials. So it's tough. The technology is moving forward, I work clinically, I think someone was talking about it. There's already, Stanford GDP is already up. We can use that right now. So someone has decided at Stanford we don't need the large trial. And it is being used right now in clinical care. And I suspect quite strongly that it's being used even unofficially in less secure clinics around the world. But people are, they used to Google it, they used to go on up-to-date Wikipedia. So I don't know if we'll ever get those trials. And I don't know if there's an appropriate short-term outcome that would be appropriately powered and cost-effective. Yeah, good question. Okay, so we got to the point where we've gone through the quantitative results. We then asked our evaluators, our Stanford genetic cardiology specialists, to write qualitative feedback about what they thought was right or wrong about various answers, the large language model and the cardiologists themselves. And they said to the cardiologists that it sometimes wasn't as thorough as it could have been, it sometimes missed things. The two things that highlighted were patient's family history, which can be important, and then they often missed risk stratification for a defibrillator. One of the most important things we do in clinic is saying, okay, you have the diagnosis, now we need to think about, do you need a defibrillator? Not everyone does. So that's something that probably should be done in clinic. And then the large language model, it's, as we've already talked about a little bit, suggested too many things. And I think when we think about this clinically, if you suggest an ECG, that's maybe not a big deal because it's someone putting electrodes on your chest, it's pretty cheap. But sometimes the large language model would suggest invasive tests. In this example, it suggested an electrophysiological stimulation test where you go through the groin, the catheter's in the heart, not an insignificant risk of error. And that's something we almost never do. So that would be sort of a pretty catastrophic mistake. Someone was subject to that. So we sent it to Nature Medicine, the results. They basically said what all of you have just said. They said, how is this like a clear advancement? What we know. They said, how does this represent realistically what happens? And specifically, a cardiologist said, when I see a patient in clinic, this is not unreasonable. I look at the ECG myself. I don't just look at the text, look at the imaging myself. I sort of thought it's a little harsh to make us do a whole new study, but we did go out and then convince Google to fund this randomized controlled trial, which we set forward to say, okay, there's probably a lot of existing data that looks retrospectively, so maybe that was a critique, there's less randomized data. And then in this study, we tried to directly address this critique about access to raw imaging. I think it's reasonable. So, for a different study design, we now recruited 10 Stanford general cardiologists. So Stanford docs who have done their training in cardiology, but haven't done extra training in genetics. And we basically gave them the same cases, but we randomized the clinicians, the usual care. So go ahead, look at this text data, look at the images if you want, but you have no extra help. Or we randomized them to the same assessment using the same text and the same images, but with a web interface they could chat to. So this is an example of the web interface that people would log into. It had all the text data. Also, you could link and access the raw imaging data. So you'll see that it says, this is the usual care, non-intervention arm, it says, you have to do this by yourself, please don't, you can't interact with the large language model this time. As mentioned, cardiologists could still see the raw images, the most important of which is probably ECG, this is the cardiogram MRI, this is an echocardiogram. And then the intervention arm was the same design, but the difference is that they had access to this integrated web test. So in that way, in this example, you could ask a question and it would give you an answer. Any questions at this point?
Yeah, I just didn't understand if the LLM is getting the raw images or the reports.
Great question. It is not. It does not get the raw images. The feedback we got from the team, and my understanding is that they can't deal with the sort of complexity of that level of images right now. They probably could deal with just the ECG, but they can't do with a big, like, the cardiac MRI has about 10,000 DICOMs in it. So, no, but how we tried to address that is we did ask the Stanford general cardiology clinicians the same questions we asked in the first study, but then we did ask this question, which is sort of an imperfect way of trying to get to that, but very bottom row. We said, when you looked at the images as a cardiologist and compare that to the text report, knowing that the large language model can only see the text report, did you notice anything clinically significant on the images? So we have an answer to whether seeing the images would have changed it to some degree. We also asked them, beyond their direct assessment, their expert opinion on the case, we also asked them some questions around their use. So did it save you time? Did it have any hallucinations? Did it miss anything? Did it make you more confident? Did it help? So just to regroup the study design. So we have a patient case. There's about 100 in total. We have a patient case. There's 2 assessments. So one Stanford cardiologist does an assessment by themselves. One Stanford cardiologist does an assessment with this web interface they can talk to. We end up with 2 different assessments for the one patient. We then, similar to the first design, gave both of those assessments to our Stanford, get confusing now, Stanford genetic cardiologists, the subspecialists, to look at those cases blindly and ask them the same questions, which do you prefer? So I think we know all this. So just to go over the
So my question is, how did you account for like, did you require them to use, like, at least prompt the AI once? Like, because I know people have different, maybe one of the cardiologists didn't even want to use the AI, or maybe one cardiologist used like 10 prompts. You know, there's a lot of variability on how people want to use the AI. How did you go about that?
Yeah, that's a good question. We didn't have any restrictions or rules about how much they could or could not use it. And I would be a little hesitant to do that because I think there's some cases where they probably didn't need it, but there's some cases that they probably did. So I think if we ask them to say, you must interact 5 times, I think that might have wasted time. It's sort of a bit artificial. We want it to be as close to clinical practice as possible. And how we saw this working clinically is the cardiologist saying, when I want more confidence, want a second opinion, I will interact. I think we addressed that a little bit with some of these questions about, we didn't ask them directly, how much did you interact? We do have that data available, like that is stored. We haven't analyzed that yet, but we have like per case, per cardiologist, how many questions we asked. So we could answer that, but there wasn't any rules about it. Yeah. Other questions? Yeah.
So I was wondering, would it make any sense to feed the cardiologist reports to the AI and then make it reassess? Then like take that and compare it to AI plus cardiologist report. Would it be like more fair comparison instead of augmented report versus cardiologists?
Yeah, if I understand the question correctly, you are proposing reproducing Amy's report, giving it to a cardiologist, and then saying, what do you think? And then comparing that to a cardiologist.
Taking the cardiologist report and then like we submitting it to Amy and then
I see.
refine your like reprompting.
Yeah.
Refine your report and then comparing those 2.
Yeah, we could have done that. That was definitely an option for the cardiologist to do. They may have chosen to say, this is what I've generated myself. I will put it into Amy and get Amy to double check it. But we didn't design it that way. Yeah. Again, I guess my focus, particularly in the context of the reviewer comments, my focus was to try and make it as clinically sort of clear at mirroring clinical practice as much as possible. And I think how we've seen people use this is they make an assessment themselves and then they sort of double check and interact with it, which is not dissimilar to how you present. But yeah, I think that's not an invalid way to do it, but different to how we thought about it. Other questions? Yeah.
So this kind of relates to the previous question that was asked, but how do you control for like expertise with prompting these things, like LLMs, right? Because like, I don't know, like maybe if you give them like 2 weeks to like interact with this, right? And then it's like they kind of learn the strategy for like prompt engineering, right? And I'm wondering if like, you know, you kind of like, I guess like in a real use case setting, I would imagine that these clinicians would have maybe like at least a day or something to like understand like how to interact with these systems.
Yeah.
Yeah.
It's a good question. I thought you were originally going to ask about different expertise in clinical care, which we did think about. And we have all of their sort of like, as a surrogate, PGY rankings for that. As levels, like how far it is. In terms of prompt engineering, we didn't really. What we did do is we didn't want the cardiologist to learn and then so we didn't want a situation where it did a couple of AI augmented cases and then go back to usual care. So what I didn't say is they all did about 25 cases each. The first half were all non-AI augmented. So it doesn't quite answer your question, but we try to say, okay, this is all your usual care. And then now you can use the AI and your next 12 will all be AI. That doesn't really count for their background. Like it sounds like how much they've used ChatGPT, for instance. We don't have a control for that. I think the only way to probably get around that is just recruit more cardiologists and sort of just get closer to that regression to the mean.
Or like implement some kind of training period beforehand.
Yeah, I guess we do. Yeah, but yeah, it's a good point.
'Cause I'm just curious, like how much variance there is in, if I'm assuming there's like, as you said, there was like some improvement, right, in the clinician plus AI augmented setting. So I'm just curious how much variance there was across like this.
Yeah, that result was from the first study. Yeah, I was gonna say something else, but I can't remember.
There's a question online. I'm just gonna allow the person to speak up, but
Yeah.
you're on. Dalibor? Looks like they might have stepped away. We can't hear you. Hello? Right.
Quick question.
Oh, yeah.
I was curious if you looked at the cardiologists and how much they scrutinize the AI responses, like were they by default assuming the AI was smart?
Good question. We do have some qualitative responses from like these answers, for instance,
Yeah.
to ask them. But we didn't set any rules around that or anything. We do know how much the cardiologist interacted per cardiologist. And then we do have an answer, which gets to this point a little bit, which is a question directly asked them, did it make you feel more confident or not? But that is our closest we got to saying, to asking the question about if the cardiologist thought AI was wrong. I guess there's also a question about did Amy miss anything? Do you feel confident? So that's probably as close as we got.
But I guess my curiosity is that when they were interacting or given Amy, were they by default thinking that Amy was producing? And how much, because like sometimes if you're interacting with like GPT or whatever, you're by default thinking they have a bigger knowledge.
I don't know by default. I could ask them, but I don't know by default. There'd probably be some variance about that. You know, tangentially, I would say clinicians are probably a little more skeptical than the average non-clinical user for ChatGPT asking a non-medical answer. So I would hypothesize that they weren't by default thinking it was right. But I don't have like a systematic quantification of that.
But when they were asked to change their response when given Amy,
Back to the original study, yeah.
yeah, were they prompted in a way? Like, how were they prompted?
Ooh, good question. So that study, no one could interact with Amy in any way. They just got given Amy's static assessment. So basically they were like secured email saying, this is that case you thought this, is the other static representation of what Amy thought. You can't interact, but you can just look at it like another sort of expert opinion. And then on their clinical judgment, you can make a decision about whether you think it's right or not, whether it's significant enough to change your report.
And did most physicians?
63 or something. I will say that's a binary thing, right? Change or not.
Yeah.
That it wasn't necessarily like sweeping changes. The results that I did show showed most of it was for like management. I would say when we looked through the data in detail, most of the time it was like the cardiologist forgot one or two things, like screening. You know, these patients, their family members need to be screened if you are diagnosed. There's one example.
Right, sorry, I thought you were done.
Yeah.
We have another one online. How does it, I would imagine the Amy system, or your implementation of it, how does it address challenges such as data bias, interpretability, and ethical concerns?
Great question. So of the results that I've already presented, we did have a seat braille question. So we asked the subspecialty cardiologist, are the answers from either responsive from the cardiologists themselves or from Amy, did they show any evidence of bias? And for both of those groups, the evidence of bias is very low, like in the single digits, and it was not statistically significant. I can't speak to like if there's something under the hood that is controlling that, but that's what we tried to do with this study. Do you have a question? Okay, so now we're back to the point where we're discussing the initial results from the randomized trial. So remember, it's cardiologist, usual care, cardiologist, usual care plus large language model. And these are answers to the questions that the general cardiologists answered after they had used Amy, basically. So the first question is, did the AI help your assessment? I find this in some of most answers a little unsatisfying. I think like if you'll see it's sort of messy, it's sort of there's a lot going on. The highest percentage was yes, probably, 40% of the time. But then 33 said, who knows, maybe yes or no. And then the same number said definitely yes and definitely not, basically. So hard to know what to make of it. It's probably helpful to some degree. This I think is quite interesting. Did the AI miss anything? My initial impression was when I looked at this was saying, okay, that's pretty good, I think. 93% of the time it didn't miss anything. But then 4.4% of the time it missed something clinically significant. I think there's a broader question in medicine of what is an acceptable number for that? A bit like driverless cars sort of situation. I think if we did this purely with clinicians, like if that number would be probably very similar, possibly higher. But you know, if your one family member is in that is a sudden cardiac death of a 30-year-old, then that's pretty catastrophic. This gets a little bit to your point. Did it make you more confident? And again, this is just as close to clinical practice as possible. Cardiologist saying, what do you think? Was this helpful or not? Similar to the prior results, the number, the highest percentage said yes, probably. But there was also a bunch that was sort of indeterminate. This I think is quite interesting. And I was talking to Jonathan about this. He says this is actually consistent. I was expecting the time saving to be a thing that was more convincing than this. But these are, yeah, NIGMs for people like NIGMs also agreeing. So, you know, what we're seeing is 36% of the time, they said by 10%. That's sort of a minority. It's the highest percentage, but a minority saving a little bit of time. This maybe gets to your question about the training. Could this higher if we gave them a run-in period? Will this change over time? Probably.
So, sorry to jump in here, this has come across multiple applications of AI. In fact, even multiple applications of technology writ large. So a favorite example is, do washing machines save us time? Like they don't, we just have cleaner clothes. So AI is not gonna save us time. We have to measure other advantages that we get from it.
That's a good point. Yes, I think you put your hand up marginally quickly.
So would it be worth stratifying these results based on the number of years of experience these clinicians have? Because they might change. If I'm a senior resident, I might have a very different opinion of how I want to go about it as compared to somebody who has just started in the clinic. They might over rely because I'm more familiar with the technology. I would be preferring this.
Yeah, we certainly can. We do have that information, and we probably will could suggest it. It sounds like your hypothesis is the more junior cardiologists will be more familiar and be able to save more time.
And I mean, yeah, our experience was like seniors are more well versed with the cases, so
Yeah,
they would be, without even second opinion, they would be 90% of the time been correctly identifying the cases.
Yeah.
So they feel like sometimes they do not require extra help. That is what I have experienced.
yeah. Let me comment on that, and then I'll get to your question. But I think that's a really good point, and it reminds me a little bit that you guys have probably all experienced this. When you go to one doctor, whether it's a primary care doctor or a cardiologist, there's a whole host of different experiences. One cardiologist maybe has missed this condition when they were junior, and then they never again, and then they read all about it, and it's very hard to control, other than probably recruiting thousands of cardiologists to get as close as you can. I think 10 is probably less ideal. That's sort of just a practical limitation. You had a question as well?
Exactly the same question as he asked. Like there is a variability in experience. So maybe like along with saving time, there is another thing like bringing consistency. Because the experience across the cardiologists is not the same, probably, the level of their expertise, education. So AI, like probably saving some time, but can bring consistency across all the.
Oh, I see. Yes, it sort of normalizes it.
Yeah.
Yeah, I like that. So this is I think it was your comment. This is how we tried to get at this point where we did have this disconnect where the large language model could not see the imaging. So it could have potentially seen other things. It was relying on the physician's text report, like a downstream summary. This is higher than I thought, actually. So then we asked, how often, as the cardiologist, did you see something that you didn't see or expect to see or wasn't well described in the text? And, almost 25% of the time, there was something not significant, but then almost 10% of the time, there was probably something significant. I think it probably points to eventually do want these models to be able to incorporate raw data.
So here, that's only before means the LLM output or the input?
Great question. It's the input.
Input.
So it said, here's the physician text report of the echocardiogram. When you looked at the echocardiogram, did you see anything? And then if you did see anything, was it clinically significant or not? Okay, where are we up to? All right. So then we now went to the subspecialty genetic cardiologist. So this is their assessments now. And we asked them these 5 questions, and you'll see a reversal of what we saw in the retrospective study. We'll see that actually there's more errors in the cardiologist alone versus the cardiologist plus the large language model. And then my take across extra content and correct reasoning is they're pretty similar. But you will see that the cardiologist alone is missing much more, which is pretty consistently what we've seen now across these 3 streams of data. Now for the direct comparison, the red being the augmented cardiologist plus the large language model, gray being entire blue being cardiologist alone. You'll see that across the entire response, which is the one that grabs me the most, we're about 48% preferred, which is a higher number. It's higher than we saw in the retrospective. Whether we call this a significant win or whether it's comparable, that's very up for debate. Then putting all these streams of data together now, this is getting a bit more qualitative and anecdotal, but the things that are in my mind is we know that the large language model has extra content. You know, it's very thorough, not gonna miss anything, but it might suggest things that are unnecessary. We know that cardiologists or physicians probably in general are less verbose, but possibly more specific. So, oh yeah.
What about extra content? Is
Extra
it possible to, for example, in the prompt, if you ask, for example, AI, you can sign and so provide any necessary information? Because in default prompting, they're ready to provide you a summary or maybe.
A good question. I'm sure we probably could. What I was about to say, I don't think that we necessarily want that actually. As a clinician, of course we don't want unnecessary information, but I think how I'm seeing the role of a large language model and the physician right now is the large language model is going to produce a lot of things. It's going to have a broad differential diagnosis. It's going to think about everything. And I think our data suggests that the cardiologist can then look at that and be like, no, I don't want that. I don't want that. I don't want that. So I think if we make it really specific, then it might start mirroring a little bit more what the cardiologist does. And maybe you can argue then that could be directly replace the cardiologist. But I think what our data has shown consistently throughout is that augmentation is what produces the best results. So I think Jonathan asked me, like, if I had to put a large language model in the clinic now, what would I do? And if I was to design a health system, what I would do is a patient comes in, I think they see the large language model first. So the large language model says, all right, this is my assessment. It's going to not miss any possible differential diagnosis, even the rare ones, even the things that are unlikely. It probably will suggest some unnecessary things, probably, but it'll be very, very sensitive, very, very sensitive. And then you can go to a human who will have all this information and probably be like, well, I wouldn't have thought about that. Maybe that's reasonable, but I'm going to throw out that. We're not going to put a needle in this person's neck, you know, something crazy. And then they may have this augmented, refined, but specific assessment. I think to your point, I'm not sure at this stage that we want to make them less sensitive. But the physicians in the room, I'm not sure how many there are. What comes into my mind is this. Oh, it's a question. Yeah.
Oh, I'll let you finish first.
Yeah. Well, what comes to mind is this classic example of clinical care that happens in the clinic where, you know, if a patient comes to the emergency department, someone's worried about clot in their lung. It's like a classic situation. There's a test called a D-dimer. It's a blood test, which is incredibly sensitive. If you have a clot in your lung, it is not going to miss it, but it has a lot of false positives. So you got to make a decision about whether you want that test. But say you get the test, that in itself is not diagnostic, but it enables you then to get a CT scan of your lungs, which you radiate your lungs, there's contrast, et cetera, et cetera. So and that's very specific. If it says you've got a clot in your lungs, it's much more likely that you do. So I sort of see that this technology working a little bit like that, as it currently stands. Very sensitive initial investigation followed by a specific refined next step.
My question was, I guess as a clinician's perspective, where do you think or how do you think clinician reactions would be if their roles are switching from, hey, I think this is your diagnosis, to, hey, let me tell you this is not your diagnosis, and saying no to a bunch of things? Like, how does that potentially impact like their interaction with patients? And because what I'm thinking is, like, you know, a lot of patients are Googling their symptoms before going in, and reaction, like from what I've observed, doctors really don't like that because they spend more time explaining why whatever Google came up with was not as relevant. But I'm just curious, like, from
I guess I just think that leads to that. I would say that most clinicians are pretty altruistic, empathetic people. So I hope that they would probably want what's best for the patient first and foremost. So I think if any technology that comes around and augments and improves patient care, I think they'd be in favor of. A specific example of, like, my patient looked at this and then that creates a lot of extra time. You know, for me, anecdotally working with doc for 10 or 11 years, that doesn't happen that often. What would I would say less than 5% of the time. And then I'm working like now sort of rare disease. But we do encourage our patients, particularly for these conditions, to not do that. You know, if I was to suspect, would it be more for a primary care doc, possibly? Would probably be more time sensitive. But I don't know. Yeah, so you're thinking if a patient goes to ChatGPT and says, this is what's going on, goes to the doctor and they're like, oh, this is annoying. Yeah, I think there's definitely a risk that leads to unnecessary tests, probably. I think we are relying, in this example, we have shown that, but we are relying on the physician saying, no, we don't need that, and spending more time doing that. So I think you're right to hypothesize that it could lead to unnecessary tests and possibly time.
Longer time.
Possibly time. But my experience, I think the reality of how often that happens would be low. But a primary care doc might be able to. Other questions?
There's a one on Zoom, but it's from 5 minutes ago.
Okay.
It's a long one. So I've noticed across many clinicians and algorithms that often default to linear assumptions like dose response relationships, risk stratification when interpreting data with known nonlinearities in disease progression. So that's a statement. How can models or explainable reinforcement learning capture these complex dynamics without sacrificing interpretability? It's a very technical question.
I guess what comes to mind, I imagine what this person might be thinking of is something like predicting sudden cardiac death or sudden cardiac arrest in the setting of hypertrophic cardiomyopathy. And he's right to assume that they're not linear. Our current models are non-linear. I guess how I would think about that initially to capture those complexities is our current models, how we think about risk stratification for sudden cardiac death is there's studies that have been done using clinical risk factors, like a collection of about 8 clinical risk factors, age, sex, presence of dangerous arrhythmias, etc. But I think an easy way to initially do that is just add the large language model output in a binary form as an extra predictor in this nonlinear model. So you could then, this would be a hypothesis, you'd have to see if it worked, but you could check existing model versus existing model plus binary, does the large language model think this person needs a defibrillator or not, yes or no? So I'm not sure if that completely answers the person's question, but that's what comes into my mind. It's probably reasonable what they say about if you let the large language model by itself try and make this decision, it might not be able to capture the complexities of that. And I think in reality, probably no cardiologist now, and I can't say in the future, would ignore our known risk factors, dangerous rhythms, if you've passed out, family history. So I would say incorporating a large language model decision as another binary predictor in these existing nonlinear models.
I think you said that there was variability in the experience of the cardiologist, but did you mention, are they all from the same health system or setting?
Good question. So for the first retrospective only, they're not. They were scattered around California, board certified, but different practices and different practice settings. Some were sort of rural, some were
For the RCT?
all from Stanford.
Because it's interesting, the proposal you had for how you would put a tool like this into place today. It's essentially asserting something like having a cardiologist anchored on an LLM response is a good thing because that probably removes some variability in how a cardiologist might approach the problem without an LLM, and then shifts the distribution in a better direction of quality or efficiency of producing this report. But if you were to, for different health systems and different practice settings, I wonder if you do want to have that type of anchoring bias, or is the kind of inherent variability in each cardiologist's set of anchors that would emerge naturally, is that better? And then to augment based on the LLM response. I think that's like, when you have the LLM being available is a pretty critical question.
Yeah. So I guess on the first point, I would push back a little bit on whether they're anchoring. I think the Stanford cardiologists would probably argue they were not anchoring. I think most cardiologists trust their own training. But on your second point about whether in other settings we do want anchoring, I think if you were to deploy this safely initially, back to your point, you probably want it as sensitive as possible. I think you probably want more false positives, probably want more people getting sent for this use case to the experts who then can confirm or refute the diagnosis. But it probably does change use case to use case. You know? I think for other use cases, if you were saying use a large language model, say, does this patient have diabetes, then you're going to get an influx of people and probably overwhelm the system, and it's an easier diagnostic challenge. So that's how I think about it. I don't know if they truly do anchor, some might. And I think we still want it sensitive and cardiologists to be aware but not anchor.
Did you measure in any way, if the AI actually misled the physician, like, basically starting a wild goose chase or an intervention that is not really needed, but now that you mentioned, like, imagine in a clinical setting, if someone suggests a D-dimer, I mean, I know it's gonna be problematic, and everyone says, don't do it if you don't specifically want to, but AI might.
AI probably would, yeah. Good question. I'm thinking it would be quite sharp. We probably can get some anecdotal example version of where that happened. To formally measure it and compare it would be tough. So I'm thinking through, the cardiologist would have to give their assessment, then talk to Amy and say, hey, what do you about to think about this? And then it would have to be convinced and change. So first of all, I suspect that didn't happen that much, so it would be hard to quantify, but we probably could go through and say, hey, let's have a look at the cases where there was most interaction and see if there's any examples of when the cardiologist said, hey, what about this? What about this? And it was led down the wrong path. And then particularly if that path ended up being the subspecialist saying that was worse than the cardiologist alone. But I would hypothesize it probably only happened, if anything, a couple of times. So it'd have to be in this anecdotal, qualitative.
Just a time check, we're 2 minutes from our scheduled end time.
Perfect, well, taking the question, I did have a little bit about what we're doing next, but maybe I'll save that for later. Do our own models, and I'll take one or two more questions. You all get great questions as we're going, yeah.
Just, it's about, you didn't evaluate based on the patient outcomes. At the end, you want to know what happened to patients, patient's assessment. Maybe the cardiologist or an AI say, for example, you can use all these, for example, assessment for all these exams and something interventions. But then at the end, you see none of them was necessary, and all of them is, for example, not so useful. At the end, for example, we could see anything on the patient. And we would like to see what happened to the patient at the end, based on the patient outcomes and patient satisfaction. Each decision that we made first was useful, and AI can provide this for the cardiologists. Because based on the patient's outcomes, it can be changed.
Yeah, it's a good question. We certainly thought about this. That's the wider point about sort of harder outcomes that we can measure. You know, I think the two things that stopped us doing for this is to get this data, just a lot of manual chart review, basically. That you have to basically go through notes and be like, did this person get a defibrillator? We might be able to use Nigham's star and see, like, who got an ICD code for a defibrillator? Did the AI suggest that or not? So it is possible to probably do some suggestion. We might even have to look at hospitalizations like we talked about. But I do think that's the next step. And I think it's a bit of an open question. I'm not really aware of many existing studies, ongoing studies that are trying to use those really hard outcomes because of those difficulties of low event rate, manual extraction, and probably expensive.
All right, that is perfect. 1 p.m. We can conclude the official portion of the talk. Thank you for being here. And for those on the online Zoom, we're gonna stop the recording and everything, and we'll see you here next Thursday. Thank you.